Okay, well, hello everyone. Welcome to the seventh Universal Healthcare Stakeholder Meeting. My name is Andre. I'm the co-chair of Healthcare is a Human Rights Steering Committee. Um, we did a round of intros, so I'm just going to skip past this slide. And I suppose I've introduced myself like 3 times now, but there's my contact information. If you want to follow up on anything at all, email, call or text, or you can book a meeting with me using that booking link. As always, want to thank Senator Hasegawa for initiating this stakeholder development process. As I said, this is the seventh meeting, the third one that we've had in 2026. I thought it was interesting looking back at all of these dates that really in 2025, we didn't get started until September 15th. So even though I may have wished that we were kind of ahead of where we are now at times, it's nice to know that we are ahead of where we were last year. And so we have been making progress and picking up the pace as we do this and kind of learn how to coordinate amongst each other. So continue to be very grateful to the senator for being so generous with his time and offering to help us in whatever ways he can. And we will continue that coordination and to meet as a group. And as always, want to thank all the stakeholders, and this is just some of the organizations. I can't fit them all onto one slide, but it's a fantastic group. We have a fairly open door policy, so feel free to work with us on inviting new folks in here. And I venture to guess that a number of folks here may be in their first one of these meetings, so maybe I can get the right logos on for the next one. But just thank you as always, and please feel free to use the group as a community. Just a couple notes on the stakeholder process. We've assembled this group from our connections. We've done a lot of outreach, and so we've been maintaining a list. It's in the agenda. You can get off the list if you like. Just get in touch with me, and I'll remove you. You can nominate people for the list, and just in general, we're here to work with anyone who wants to be here and is interested in helping us move this work forward. Just kind of reviewing some of the goals that we've developed through this group and checking in on some of their progress. So we have developed 5 bills through this group, and then if you count the original Washington Health Trust that predates this group, that's 6 bills that we kind of have treated as this space as a development for those. And so we're always looking to get more buy-in from stakeholders and improve the policy. The Washington Health Trust itself is part of that, the financing model in particular. So we continue to work on that, and I think have a ways to go on that. In the past, Senator Hasegawa has carried all of these bills, and then in the House, it's been Representative Lisa Parsley. So what we are hoping is that we can broaden that legislative constituency with more prime sponsors, more co-sponsors. Senator Hasegawa has made it clear that he has no pride of authorship on these bills, and if it is good for a strategic reason to hand a bill off to another legislator, he is happy to do so. And we believe that just having more legislators working on this stuff is a good way to make progress. We've talked about trying to get a work session in the healthcare committees on expansion and deprivatization of public health plans. Last month, the update was that we had sent that request and we had to put a deadline on it, and they had a couple days left on that deadline, but we are now quite beyond that deadline. So we can kind of discuss if there's further action to take there. Also have discussed the chair of the House Healthcare and Wellness Committee, Dan Bernowski, who we had heard was stepping down, and now we hear is not stepping down, but I can offer a little bit of update on that. Liaising with the Universal Healthcare Commission. Our state has a Universal Healthcare Commission, and so we try to be active participants and public advocates in that space, and then to help bridge that work to the legislature, because we have observed that there can be a sort of gap between the work that the commission does. Ultimately, they only can make advice to the legislature, and so the legislature needs help when it comes to turning that into legislation and getting it passed, and that's one of our roles. We also want to work with the Healthcare Authority, whose director is Ryan Moran. We have yet to meet with Ryan Moran or a relevant staffer, so that's something we continue to work on, as well as getting a meeting with the governor. Obviously, the governor has a lot of power and can help us move things forward. I can report that I have sent off a request for a meeting with the governor, so we hopefully will get some kind of confirmation on that. Still yet to reach out to Ryan Moran. But just wanted to give folks a sense of what we had done on the work session. So this is a letter that we sent. We sent it on July 10th. Sorry, we sent it on June 11th and requested a response by July 10th. So we're well beyond that deadline now. We did not receive a response or confirmation of receipt from either chair. So I think the first question is, do we want to escalate this further, and how can we do that? Happy to stop here, answer any questions, and take suggestions. Uh, we sent this letter, but we haven't really done anything since. So now that the request is out there, it would be interesting to see if there was more we could do, including collecting sign-ons would be one way to do it. Do folks have any questions or suggestions about this request for work session? Go ahead, Catherine.
Sorry. I just feel like we shouldn't be nags, and we should just let their response be a reflection of their, ambivalence towards the issue. You know, that's my opinion.
Thank you for sharing. I think there's always a push and pull there, of course, as advocating is a part of our job, but also we have to be intentional and effective with where we put our energy and priority. Go ahead, Lindsay.
Hey, yeah, I know as a former city council member, if I got one letter and didn't respond, I hope people would give me benefit of the doubt. And so and at Cleveland, Dan Bernowski, I think they hopefully want to do the right thing, whether they're moving in the right direction is my question. I guess my question is specifically, are we trying to tie the work session to any specific bills or making sure it's like connected to the meaning of this coming legislative session? Because typically by the time we get to January, like unless it's a bill or a budget proviso, it's going to get deferred until after session.
Yeah, that's a good question. And I would say that we attempted to leave some room for them to work. So, what we said here was we wanted to discuss the expansion, consolidation, deprivatization, and universalization of Washington's public health programs. Now, we do have bills tied to many of those, but we didn't cite the bills directly because we thought, let's give them a little bit of room to decide what they would like to cover and see if that makes it a little bit easier for them to say yes. That did not apparently work. Maybe as a polite follow-up, we could drop some bills, say we want to talk about these bills specifically, and maybe that helps. So that could be a small follow-up that's not a nagging escalation, if you will. Anything else on this one? I'm going to be trying to stop and do ongoing discussion a little bit more than I have in the past, where usually we do everything at the end. Go ahead, Richard.
Uh, I'm not sure if this would fit into the intent behind this, but I am aware that maybe not these two individuals who are sent the letter, uh, but a lot of these people are in the throes of political campaigning for re-election in the 2026 November election, and therefore are keen on, maintaining a high profile and so on in their respective districts and around the state. I wonder if we could take advantage of that by just putting on our own event of some kind, um, and inviting these folks and anyone else to be there. Yeah, a lot of these people are not in any dire threat themselves, but having a kind of a political event, maybe sometime in September or something like that, might be an opportunity to raise the issue a little bit more than just exchanging letters or something like that with these two individuals. Just an idea. That may not be the tone that we want
I
to
like
set here.
that.
I appreciate it though, and I like that idea a lot. So maybe that's something that we can discuss further. Um, Go ahead, Katie.
Yeah, thanks. I agree with Richard. I think helping them in this busy campaign season is probably a pretty attractive thing to do. I wonder also if we preface it with, we'd like to hear about bills that you are considering that we could promote to the public.
Yeah, I think that's great as well. I'm going to go ahead and move on from this one. I appreciate the discussion. I think there's some good ideas, so we'll take that back, to our follow-ups and see what we can come up with next. I also wanted to give a report out from a meeting that we had with Speaker Jenkins. This helps set the sort of tenor of where things are going. So, um, Speaker Jenkins, 27th Legislative District. She's Speaker of the House as well as Chair of the Rules Committee, so big leadership here. Her primary emphasis was that defending the millionaire's tax is everything. Um, she also said that she considers sales tax, property tax, and B&O taxes all to be maxed out. Those are the three primary forms of revenue for the state budget. So taking that, her next emphasis was that we should expect an all cuts budget this year. That is very rough for healthcare advocates like ourselves. We may not want to just accept that without any pushback at all. And in fact, it was not until we pushed back a little bit that she did acknowledge that there are some opportunities for smaller revenue, some revenue bills that did not make it last year and could be passed and raise revenue in the next session. We talked to her a little bit about the chair selection, and she emphasized that that is a caucus decision, encouraged that advocates should not lobby for their preference on healthcare chair. One thing I did not mention at the time, but I thought it was worth mentioning because she did, I think, defend Dan Bernowski, despite the fact that we've had some challenges with him. And one of the things I emphasized was that we have not been able to meet with him. So one suggestion was, if you can't get a meeting with the chair, try to work with the committee members, and maybe the committee members can help you get that meeting. But the other thing to remember about Dan Bernowski is he did vote against the millionaire's tax, and that was her first emphasis of the most important thing. And and shared that there have been others who have had challenges working with Chair Bernowski. So I believe this will be settled after the November election when they know what the next legislature is, and then the caucus will get to work on that decision. So I would say this is still up in the air. It sounds like we have not gotten a firm confirmation one way or the other, and we're not going to get one until November. But I just wanted folks to understand what we had heard from the chair about this. Next up is that she did suggest that a bill that did not pass last year made it through rules, I believe. So very close to passing, which would have put a cap on medical interest debt. She said it was the hardest bill, that she was not able to get to the floor this year, that it should be highly prioritized, and if we can hit the ground running on day one, if we can get a companion bill introduced into the House, we should be able to get that bill done. So I think we should take her up on that offer, and support getting that bill through in a timely way. Last, she was not super familiar with Medicaid deprivatization, but sounded interested when we told her that there are potentially significant savings over $1 billion annually associated with that, and asked us to send her additional information. So we thought that that was promising. Even after hearing that it's a no cuts budget, we sort of suggested that Medicaid deprivatization is more of a savings than it is a cost. Go ahead, Catherine.
Sorry. Regarding the second to last one, the medical debt interest cap. I've been thinking about that one for a while. I used to hang around with a bunch of veterinarians, and one of the things that they said is when they went to school, not recently, their loans for becoming a vet, their interest rate was capped at like 2%. So I know though it was a 1% cap on medical debt for interest rates. And I know that's not very much at all, but have we considered, or do we want to maybe consider increasing that to like something like 2%? That, might be
I think that should all be under on the table for discussion.
Mhm.
I know that originally it was a much more robust cap, maybe 0%. I can't remember, but it was a very robust cap. They scaled it back to hopefully get it through, but then it didn't make it. So it's a little bit up in the air. Where's the sweet spot? But I think that's the opportunity of reintroduction. Go ahead, Bruce.
On the last one, Medicaid deprivatization, if she wanted more information, so first point, was it sent to her? Second, for me, this is the way to start incrementally. As you said, Andre, it's a savings of 900 million or more based on 2023, 2024 figures. And the Washington State Medical Association passed a resolution endorsing it. So, and finally, it doesn't require a bill. It's just administrative. It requires the healthcare administration deciding to do it and the governor okaying it. So I would, if she's expressing interest, I'll volunteer if you want to send her something, but I would take this opportunity. Thanks. Over.
Thank you. And yes, information was sent to her. I think it's unclear if she has looked at it. I think what I will say is from my work with legislators in the past is that the more you can make it digestible, the more effective it is. So I would say if folks feel that they have useful information that can be summarized nicely and be presented in a persuasive and convincing way, I would encourage you to send it to her. We will continue to do some outreach here and see where she is on it. So maybe at the next meeting, we can let you know if we've had any further conversation. Okay, moving on. I want to introduce the Healthcare as a Human Right Coalition. Some folks may be aware of it, some folks less so. But as I introduced myself, I'm the co-chair of the steering committee of Healthcare as a Human Right, but I'm the executive director of Whole Washington, and Whole Washington is a member of Healthcare as a Human Right. They call it a grassroots community labor coalition, which means that it's very broad. It covers labor unions as well as providers and health boards and grassroots advocacy organizations. So this is a smattering of the organizations that are part of Healthcare as a Human Right Washington. And if you were to join, you would be in very good company. So we do encourage all organizations to consider joining. And just a little bit about that, there's basically two tiers of joining, or maybe three. So I'll say that the bottom tier, the easiest tier, is you don't have to join in any kind of official way to start participating. So you may want to just start by showing up to some committee meetings and checking it out. But for full membership, you get a voting privilege. You get to vote on our legislative agenda. And that's something that can be done if you are a dues-paying member or you're engaged. So dues or engagement, but not necessarily both. The other tier is allied membership, which basically means that you agree on the values, but you don't make a financial or participation commitment. And that is still very valuable. We really encourage that if you're not ready for full membership, to consider allied membership. It's why not. But there's lots of ways to be engaged, and we'll be talking about some of those over the next few slides. Just a little bit more information about the structure of this. So there are four primary committees on healthcare as a human right. The steering committee and myself co-chairs that with Nathan Rodkey, who is from Washington Community Action Network and with us today. The labor table is co-chaired by Carrie Wallace, who is with Washington State Nurses Association, as well as the board chair of Whole Washington, and Richard Burton from AFT. Policy Committee, Thomas Kennedy, who introduced himself earlier, and Hawa of the Community Health Plan of Washington. And then the HUCS Committee, which is a shortened name because Universal Health Care Commission Committee is too much, but this is a committee that tracks the work of the Universal Health Care Commission and is co-chaired by Jane Grafton from Whole Washington and Sherry McEvoy from Healthcare for All Washington. So I'd like to give each committee some opportunity to talk about their work and introduce themselves a little bit. So I'm happy to hand it off to Richard now to talk a bit about the labor table.
Yes, thank you very much, Andre. Hello, everybody. The slide kind of says a lot of the items that I wanted to talk about. We do have an upcoming workshop scheduled for the 19th, a week from today, via Zoom. This will be kind of a repeat of the in-person workshop that many of our activists did in Wenatchee here just several weeks ago at the Washington State Labor Council convention there, a well-attended workshop. And it's been carefully adapted for Zoom format. So if you haven't had a chance to hear this presentation, I hope that you will tune in. And it's an opportunity to kind of hear some of the details, especially around labor's involvement and potentially bigger involvement in this ongoing campaign. Our next meeting for the labor table is going to be the 25th of August. That's the following Tuesday. And we meet monthly on the fourth Tuesday of every month, unless some odd holiday or something comes along that gets in the way of that typical cadence of meetings. The one other thing I want to be sure to highlight, of course, is that since we are the labor table, we would be remiss if we weren't thinking about Labor Day coming up in the first week of September, where there will be a whole variety of different Labor Day events taking place across the state. And we want to be a presence at as many of those as possible, staffing tables, passing out literature, getting people to sign up, and building our movement. For those of you who've ever attended a Labor Day event, they certainly are made up of largely of labor people, labor union members and so on, labor families, but a whole lot of people who aren't in unions, but just support labor and support working people and the issues of concern for our labor movement and for working folks also come. After all, there are hot dogs there, and there's usually people playing guitars and other fun things. So please put it on your calendar that we've got plans to be a presence at the Thurston Lewis Mason Central Labor Council, the Pierce County Central Labor Council, the MLK Labor Labor Day event, and also the Northwest Washington Labor Council event up in Burlington. So lots of different opportunities to plug in, meet other people, talk about this important issue, and build our movement and enhance our capacity to get this thing through. And that's the end of my presentation.
Thank you so much, Richard. And for folks who haven't seen that graphic before, that was a promotional graphic for a statewide single-payer resolution that the folks on the labor table did a ton of work to pass through many, many individual unions and central labor councils before ultimately getting it through the state labor council. And so thank you to everyone who helped with that. And it's really fantastic that we have laid that foundation within the state labor council to kind of take this further. So go ahead, Bruce, I see a hand.
I think that sounds great, but I have a question. Is single payer an essential part of the proposal, or is universal health care the part of the essential part? Thanks.
Yeah, and I think what I would say, and we've discussed this in the past a bit, but I think single payer should not be interpreted literally. I think that it is an aspirational, it's a model and it's aspirational, and that we are pragmatists and that we recognize that there may be steps along the way, and that single payer is not just one thing. It is very simple in a textbook, but in actual implementation, they're often different. And so we need to find what is appropriate for Washington state, right? We need to find single payer with Washington characteristics, if you will. And so I think that that may, we want to maintain some flexibility there, but it does help guide us in terms of what our core goals and principles are.
Well, I just say that words matter. And I think if universal healthcare conveys what you're after, I would in the future, uh, I'd recommend switching to that language. But I just put that out there. I don't expect everyone to agree. Thanks.
Thank you. I appreciate that. And I will just briefly say, whole Washington tends to say universal health care. This resolution was passed through the State Labor Council. They used the language single payer, and we certainly support that. But I think for a lot of the reasons you say, we tend to say universal health care, or sometimes we say universal public health care because we're more interested in expanding public health care. But that does not necessarily mean it's all one single payer. There can be multiple public programs. And so that's one way to kind of square that circle. Moving ahead, Policy Committee. Thomas, would you like to talk a little bit about the work y'all do there?
Yes, the Committee hears arguments all year long about what policy is important. And then near the end of the year, we start building our policy agenda by voting, like having proposals go to the Policy Committee and voting on those proposals there, and listening to it. Then later, we actually finalize the agenda and then ship it to the general meeting so that our general membership can do the final vote to see what actually is on our policy agenda. So just to give you an idea of the kind of things we talk about, upcoming meeting topics include improving the health benefit exchange, including Cascade Care, which, if you don't know, is our public option here in the state that was developed under Governor Inslee. Addressing healthcare revenue and federal cuts, public banking. So excited to see Marco Rossi here from Washingtonians for Public Banking. For that reason, we're hoping to get him in to talk to us. And discussing Oregon's universal healthcare pathway progress and challenges. For many of you who maybe have missed the last Hux meeting, we actually had Warren George come talk to us about the challenges they're facing. And since we're trying to follow a similar pathway, they're a little bit in front of us. It's always great to get that feedback. So we talk about all things policy. Our next meeting is on August 18th at noon, which is less than a week from today. And you can email me or message me if you would like an invite to Hicker Policy.
Thank you, Thomas. Next up, we have the Hux Committee. Jane, would you like to talk a bit about Hux?
Yes. Hello, everyone. Yes, I'm Jane Grafton, and along with Sherry McAvoy, I'm co-chair of the Hux Committee. And we're the Healthcare is a Human Right Committee that represents advocates with the Universal Healthcare Commission and to some degree with the FTAC, which is the Finance and Technical Advisory Committee. So the next very important Universal Healthcare Committee meeting is September 3rd from 2 to 5. It's an in-person and an MS Teams meeting. And as part of that meeting, we were invited to participate in an advocates roundtable, and which will be a series of questions and conversations between the Universal Healthcare Commission and advocates. And another important item on that meeting agenda for September 3rd is that the Commission will vote on whether or not to incorporate universal primary care into its work plan. I'm not sure how often they have changed their work plans, but I think that's a sort of a major milestone. Every single month, there is either a UHCC meeting or an FTAC meeting. And it's critical for us as advocates to submit public comment to these meetings. And I say critical, I think, especially as all of you here are representatives for your organizations and communities and speaking for your constituency. It's really important to submit those comments either orally or written to those meetings. And written comments are included in the meeting packet if they're submitted 2 weeks prior to the meeting. And oral comments are accepted up to 5 p.m. Before the meeting, the day before the meeting, or sooner than that. And in order to submit comments or to get invites to this upcoming meeting, the email address here for the Healthcare Authority is how you would reach them. And I think that is all I have to say. Thank you.
Thank you, Jane. And I will just say that the commission is a little bit hard to know about and a little bit hard to navigate. And so I think that's the huge value that the Hucks Committee provides, is just kind of being a tour guide. So this may be a little bit intimidating. How do I sign up? When is the meeting? But that's what the Hucks Committee can really help you with. So if you're interested, please do get in touch and we can help you get oriented.
And
Okay,
then I
so-
would just add that August 31st is our next meeting, a huddle before the September 3rd UHCC if you want to join us.
Thank you so much, Sherry. Yes, they tend to have one meeting before to prepare and then one meeting after to debrief on Mondays. So that's the schedule to keep in mind. Thomas has put his email in the chat if you want to be added to policy committee, and I'm sure that Jane or Sherry can share their contact information as well. So getting into our stakeholder bills, this is the overview. So the Washington Health Trust was introduced into both chambers. It is a statewide universal health care bill. We had a trigger bill that was effectively trying to trigger, based on some federal action for the federal support that we're trying to get, a constitutional amendment that would establish health care as a right in Washington, a deadlines bill for the Universal Health Care Commission, and then 2 Medicaid bills, one which expands the eligibility threshold, and then the other of which is the deprivatization bill. And so that's 6 bills in total, and we will be going over some updates on each of them, starting with the trigger bill. We recently met with Senator Jessica Bateman, who is on the Senate Healthcare Committee. She offered to prime sponsor this bill, which is very exciting. And we are optimistic that this has a very good chance to passing, since it's already made it all the way through the Senate once. The language is currently being developed by Senate staff, and we should be able to take a peek at it in mid-September. We've done some development on this bill. Last time we all looked at certain aspects of it together, and I think the main takeaway that we had for this bill was that the governance board, people broadly like. So basically part of what's specified in this bill is the governance board that we would create for a universal health care program in Washington. And folks were pleased with the governance board, but thought that it should also include a patient representative. So that's one concrete development that we can add to the new version of the bill. The deadlines bill for the commission, we also have had some good developments here. So the first is that originally we had several deadlines in the bill. There were certain interim deadlines, and then it culminates into a final legislative recommendation. And we more or less have decided, based on discussion, that really we should remove those interim deadlines. There are several advantages to that, including that it can basically get the bill down to a zero-cost bill, which is going to be very helpful in terms of getting it passed. So as of right now, we're still mostly looking at kind of directing the commission to make their final legislative recommendation by 2029, so that the legislature can pass it by 2030 and keep us on a pathway of universal health care passing by 2030. Right now, this is another bill that's being worked on by Senate staff and will also be ready in September. And Representative Partially again, on the House Healthcare Committee, as well as a member of the Universal Healthcare Commission, has volunteered to prime sponsor this. So that is really wonderful support to have, as well as the support of Insurance Commissioner Cooterer. Actually, Insurance Commissioner Cooterer was the first person to recommend that we pursue this, and since then was elected to the office of Insurance Commissioner, which means that she now sits on the Universal Healthcare Commission, although I think that she technically sends a delegate. But OIC is a member of the Universal Healthcare Commission, and it is good to know that they agree that a deadline is helpful for the commission to be held accountable and to stay on track. Next up is the constitutional amendment. Now, this is one where we do have language. The group consensus was that we should reintroduce this bill. There are some really good tactical and strategic things that we can do with this bill. It's fantastic for messaging. So even if it doesn't pass, or we may see after November if we have a 2/3 majority to pass this bill. But as of right now, this is the language we have. I'll be happy to stick on this slide for just a minute or two so folks can read it, but it's not a long bill at all, which is another advantage that it has. And here's what it reads as. I won't read it out loud, but I'll just leave the slide up for another minute or so. Feel free to read it, and hopefully you like the language. Let us know if you don't, because we have until December to workshop that language and have it filed. Go ahead, Thomas.
Yeah, so we base this off the Oregon constitutional amendment that they passed in 2021. And this has the Oregon amendment has held up in court and has actually protected healthcare rights. However, we in the Hucks meeting, we did hear feedback that Oregon wishes they had put more teeth into this. And also that there is some worry about it impacting budgetary concerns. Now, I think we in the healthcare advocate space would argue that healthcare is important, even in a budget downturn. But there are concerns out of the Oregon movement around that we have heard.
Thank you for sharing. And yes, I think that we want to take both the strategy, but also the learning. So that's one of the advantages of having Oregon to the south of us, because they are working on all of this. Next up is our Medicaid bills. So I think the main development that we've had here, and we talked about it last time, but I think after that discussion, we feel more confident about it, which is that it makes sense to combine our expansion and deprivatization into a single proposal. So that also helps us get the total bill count down by 1. It's a little bit less to track. In addition to that, so the first thing is that the savings from deprivatization can fund the expansion, but it's only possible with initial investment. So there will be a need to raise revenue to make this happen at all. The savings will happen arguably as soon as the first year. We've seen that in other states, but in terms of funding, we have identified, it's sometimes called the Walmart tax, but effectively it's a tax on large corporations who insure their employees through Medicaid. And there was a bill introduced last session that would basically tax those employers. And so we think that that's really sensible revenue for a investment in Medicaid. We have not confirmed that that will be possible with Senator Alvarado. We as she is the prime sponsor, we want to make sure that we're doing that coordination, and we have reached out. But everyone that we've talked to finds this to be a promising direction to take this. Now, in the last version of the bill, we had raised the threshold up to 300%. And after reviewing it, it seems that it would be quite a bit more viable to do something along the lines of setting it to 200%, and only expand beyond that, as savings and funding allow. 200% aligns better with Washington's poverty care laws, and so that is easier to imagine that we would be able to guarantee, while expansions beyond that would be much more dependent on the financing. Let's see. Other things about this, which is that we have tried to get the Universal Healthcare Commission to take this on as a area of interest, and they've kind of punted on it. So what they have said to us is that they don't really have the authority to make a decision on this. They don't have the authority to speak on behalf of the healthcare authority, even though they are a subdivision of the healthcare authority. And so, more or less, we've been encouraged to take this conversation to the broader healthcare authority and not do this advocacy within the Universal Healthcare Commission. So that's the direction that we'll be going. As Bruce mentioned earlier, with the support of the healthcare authority, this would not even need to be a bill. So, fingers crossed, we'll see. And the other thing that we've heard is that, like a lot of things in the state, legislators would feel more comfortable pushing for it if they had a recent study that specifically looked at Washington state, so not a national study. And there are some organizations that may be pushing for that study to happen. And so we will try to coordinate with that as best we can. See a hand from Katie. Go ahead.
Yeah, thanks. I don't know if this is the right time to talk about this or maybe just to add it to an agenda in the future. I've been involved in some League of Women Voters healthcare groups nationally, and they tried to get a resolution through the National League of Women Voters group to support universal health care, or I'm sorry, to support deprivatization of healthcare. And people got really hung up on the word deprivatization because they thought about private hospitals, private clinics. In some of the reading I've been doing, the corporatization of healthcare seems to land a little bit better with people in understanding. We don't want these big businesses and shareholders profiting off of people's health needs. So, I'm not sure where we could talk about that more, but I'd like to just put it on the table at some point. Thank you.
I appreciate that. Yeah. And I think that, so I'll start by saying this is not the first time that we've heard that maybe deprivatization is not the best word. I think it depends on the context. In this space, I tend to just try to use technical language. It's not strategic language per se. So we can develop different messaging, different strategic language. But I think one of the important substantial content things to understand is that we are only talking about deprivatizing the insurance layer, right? So Medicaid is a public insurance program. Right now it's administered through private insurers. And what this would do is it would take that administration into the state's purview. So in terms of private hospitals, family practices, your local doctor, to them, it's really just going to make their life easier. There's no intrusion on the way they operate. If they take Medicaid now, they would take Medicaid after this, and they would probably have an easier time using it. But we can continue to develop our messaging and strategy and details on this. So thank you. Okay, and then the Washington Health Trust itself. This is the biggest bill. There's the most to kind of untangle here. Representative Parsley has also said that she would like to prime sponsor this one. So she's the one who prime sponsored it in the past. I think it makes sense to stick with her. So it's good to know she's still enthusiastic about it. We have begun some legal review on this. I don't have a detailed update on it, but there's already some useful information coming through that legal review. Also, we discussed last time Medicare integration, and kind of what I would say right now, it's not fully decided, but I think that at least when we're talking about the legislative space, that it makes sense to kind of move those federal components into the trigger bill. That kind of just separates the federal component from the state component, makes the health trust itself a little bit more straightforward, and removes some of those concerns that it's only possible with federal action. And then the other component is the long-term care program. Now, when we had the survey last month, most stakeholders suggested that we keep this section or expand it. I still think that it may make sense to do that, but in a separate piece of legislation. So I think that where we are on both of those is maybe it's not fully decided yet. Maybe we need to continue to try to build some consensus here, but that's kind of the latest state of play on those. On the funding side of things, I think there's more work to be done here too, but It does feel that the more we discuss it, the more that there is sort of agreement that employer payroll is the main funding mechanism that we have available to us. And so, when we're talking about revenue of this size, it's, it seems to be likely that employer payroll will be a major component of the funding. And then we had a meeting with the building trades, and one of the things that they said, we don't have time to get too into the details on this. So what I would say is we have a form of exemption for Taft-Hartley plans, but it's not necessarily a full exemption. And it was suggested by the conversation we had with the building trades that they would be more comfortable if they could just confidently say and know that they are just completely, fully exempt. If you have a Taft-Hartley plan, nothing about your life changes. And so I just wanted to acknowledge that and say maybe that's something we can look into. As it currently stands, you are fully empowered to keep your Taft-Hartley plan, but depending on how much you pay into the Taft-Hartley plan, you may be required to pay an additional amount on top of that into the state plan. So that's kind of the point that is under discussion there. Also wanted to mention a couple other bills and priorities just to keep in our radar. So the medical interest debt interest cap we already talked about. The other bill is the Keep Our Care Act, sometimes called the Corporate Practice of Medicine. Folks following last session may be aware that a sort of lightweight version of this bill passed, but a lot was stripped out of it before it passed. And so the question is kind of, do we want to continue to push on this further? Were some of those provisions that were removed, should we give those another go? And I think it's very likely that there will be something put forward in the next session. The last is the consolidation of the Public Employees Benefits Board and the School Employees Benefits Board. So those are two fairly similar plans with fairly similar governance structures that are both managed by the state. There was an attempt to consolidate them 2 sessions ago. It ran into some issues with the stakeholders. And so right now what we're hearing is that they probably will not be pushing this as a bill, but instead trying to explore a study to show that there are some real advantages and administrative savings there. So that seems to be what is coming down the line on that one. Go ahead, Bruce.
I'm a bit delayed because I had to look up what a Taft-Hartley plan was. And if I understand it correctly, it's a labor union negotiated health care. Is that right?
I believe so. I don't
Okay.
know if this is a requirement. A lot of them are multi-state plans, which is one reason why it's relevant in this space,
Yeah.
because taking a statewide program, if you have a plan that spans multiple states, there are some nuances there.
Yeah. So I think we should take a lesson from the fact that these folks wanted an exception to keep their insurance. And we can still have universal health care, but people can have choice, including keeping their insurance. But that's different from single payers. So I don't want to be a broken record. I'll stop there.
Thank you, Bruce. And I'll just emphasize one more time that the exemption to keep the plan is there. The question is, will they have to pay anything at all into the state plan? And right now, the way that it's set up is basically they have to pay the difference. So if they're kind of under the spending requirement, they would have to just pay whatever's left after their Taft-Hartley plan. But we could consider and explore a full exemption. So even if they're under the spending requirement that everybody else is paying, that maybe they just get an exception for their Taft-Hartley plan. So Catherine first and then Richard. Catherine?
Oh, good. Richard's whose brain I wanted to pick on that Taft-Hartley. Because I'm thinking that for most of the Taft-Hartley plans, they should be able to, they would receive full credit. The only thing that would probably bring them up over would be are like high paid executives in corporations, are they allowed to participate in the Taft-Hartley plan, or do they have separate plans of their own? Because that would be if they're paying salaries of like greater than $500,000 a year. Maybe longshoremen. Do longshoremen make more than $500,000 a year? No. Okay. So I'm thinking it's just, if that's what would make it cost more, is those multi-million dollar salaries. So I think it probably could be, and I think this would be a good question to ask of our legal review. It could be written in some way to fully exempt the Taft-Hartley plans as long as they're multi-million dollar salaried CEOs and such, and administrators were not part of the Taft-Hartley plan, right?
Thank you.
Yeah.
We'll continue to investigate that. And I'll just very briefly say there is a balance between sort of carrots and sticks. If we let everybody just opt out and not participate, then the plan may not work at all. Whereas if you coerce everybody into it, you may not have the political support. And so you have to create good incentives to participate, provide some options and flexibility for those who need it, maybe not expect everyone to enroll on the first day. And that's what we're trying to balance. Go ahead, Richard.
That very point, Andre, was what I was going to start with. Is that the many of the building and construction trades unions are very proud of the Taft-Hartley or multi-employer plans that they have fought for and negotiated for decades. So there's just this political question of whether they want some outside entity coming along and sort of usurping, from their perspective, the work that they have done for so many years. So just in due respect to all of them, our conversations with them need to continue to acknowledge that important work and legacy that so many of their union leaders and activist members have fought for. The other feature to it that's sort of complicated is that the trust bill as it stands right now, as Andre was mentioning, even if we were to carve out the Taft-Hartley plan beneficiaries, there would still be the question of how the employers would be asked to pay. Many of these employers, in addition to hiring building and construction people, are also got their hands in other elements of the economy. So it's a little tricky to figure out what portion of their bill that they would be asked to pay, these large companies that have to do with their own members. But I should say also that there are cases, every building and construction trade union is different, and not all of the Taft-Hartley people are building and construction trade people. The United Food and Commercial Workers Local 3000, largely representing retail and grocery workers, they also have multi-employer plans. So it's a cross section. Also, the stagehands unions have multi-employer plans. And we need to just continue to have a dialogue, a respectful, thoughtful conversation with these various union leaders and activists. Again, beginning every time by acknowledging the work that they have done. And I'll just part with the fact that in many cases, they have a kind of a bitter taste in their mouths from the upshot of the Affordable Care Act debate, where they feel as though they were penalized from that bill that passed, the Affordable Care Act bill, or Obamacare as it's known. So there's a little bit of suspicion of healthcare reform efforts on their part, not without reason, because of that relatively recent history that many of them experienced. Okay, end of report.
Thank you, Richard. And I will just end this slide by saying one thing that was made pretty clear, because we actually in the last meeting that we had with them, we kind of ran through the numbers a little bit. It was maybe napkin math, but we actually came to the conclusion that they would probably pay less under the state plan, but they made it quite clear that even if they were saving a couple percentage points in cost, they would almost certainly maintain their Taft-Hartley plan. They would not want to switch onto the state plan if given the option. And so I think we need to recognize that it's not just about cost. There are other things that motivate their decision here. Okay, so I want to move on to now an organizing framework and campaign plan. We've been kind of talking about the fact that it's not all policy. We need to have some firm plans on what we're going to actually do. And all of this is under development. So kind of like the bills, I think there's lots of room for um, feedback, discussion, improvement. And actually, before I move to this next section, I want to just reshare the link to the actual, let me see, framework. And some of you probably already have it, but here is the organizing framework and campaign plan document. And feel free to leave comments on it. So you should be able to highlight a section and add a comment, open discussion, bookmark it, take it back to your team, leave comments in the margin, and we will make this as solid as we can. But I wanted to start with an organizing framework because it's hard to come up with a real legislative agenda and a strategy if you don't have your framework. And so I'm going to actually start by just kind of doing this high-level overview, and maybe we can look at it in more detail after we go through it. So the general principles are healthcare first. I just want to say that's not a statement of value. We're not saying that it's more important than education or racial justice or environmental conservation. But what we are saying is that this group and this coalition and this space is a healthcare first space. It's just a description of what we are, and it helps us focus. Number two, direct and transparent communication. And we mean that both inwardly when we talk with each other, but also outwardly. We want to directly advocate for what we want and make that clear. And we need to find a shared collective voice and then deliver clear recommendations and demands to the change makers. An inclusive, everybody in movement. So what we mean by that is, we need to grow beyond this group. We need to have a broadly representative backing coalition. So we need to represent the diversity of Washington state and its industries and its people. And so we just want to make sure that we are doing that outreach and that folks feel that they have space here. Fourth is a growth orientation, meaning we haven't won this yet and we need more political power to win. And so we can only do that if we grow. So more individual people involved, more organizations involved, more fundraising, and we just need to grow. Number five, all options for political change on the table. So legislative, ballot initiative, administrative. I've got a list of them on the actual document, but we want to have what I call a diverse strategic portfolio. And then hyperlocal to global change. So we do primarily focus on the state legislature and on state level action, I think for very good reason. We've correctly identified that that's where there is the most potential for change over the next couple of years. But at the same time, change can happen in a single clinic or a single hospital district. And the movement for universal healthcare is a global movement that goes back hundreds of years, and we are a part of that. So we want to acknowledge the validity of doing work on all of those levels. And then last but not least, we need to combine the powers of incremental and radical progress. It's not that one is correct and one is incorrect. They both contribute to political change. On the campaign plan itself, let's start with the 2026 interim. That's happening right now. The primaries just happened. We're doing the stakeholder and policy development right now. General election coming up in November, so there may be some elections of consequence that we may want to take an interest in and influence a positive result for the universal healthcare movement. And then we want to pre-file these bills by December, right? And so whatever it makes sense for us to pre-file, we need to get ourselves in order before December, and that's what we're doing now. The next section I put in a 2-year biennium, right? 2027, 2028. I think there's a lot of good reasons to do that. So starting with 2027, right, we're going to kick off with a legislative campaign. Legislative session is going to run from January to May. Technically, it's a little bit short of May, but we want to have a strong showing in the legislative session. We want to give them everything we've got. We want to see what we can get passed and see what things don't pass. And then we are looking to bring this to the 2028 ballot, which means that we would need to launch our initiative campaign in May of that year. So that works out really well in terms of after that legislative session is over, anything that they haven't passed, we can start sending to the ballot. We have to gather those signatures in that year. But right now, technically speaking, there are different types of ballot initiatives. And I suppose if folks want to advocate for an initiative to the people, there's still time to do that. However, we are advocating primarily for an initiative to the legislature. And part of the reason for that is if we gather the signatures, the benefit is we can go into the 2028 legislative session and try again, and we can force them to vote on whatever we have sent to the ballot. And so the Washington Health Trust, whatever version we develop for the ballot, if we get the signatures, we can force the legislature to vote on it. Now, they may not take us up on that offer, and they may decide that they want to send it to the ballot. That's their decision, not ours. But if they send it to the ballot, then we have a statewide get out the vote campaign to win. And so this is all culminating towards a big November election, which is a presidential election. And the question will be, can we win universal health care on that ballot? Can we win majorities in the state legislature and in Congress that will support universal health care? Because it's not just about passing it, we need to see it through. And so starting in 2028 and further, we'll have a new administration. And if we have a friendly federal administration, we can kind of move on to the next phase of this, which would be getting those federal waivers, passing federal legislation like Medicare for All. If we have an unfriendly federal administration, well, then we may be more limited to state level policy, and there will be plenty of additional state level policy for us to consider at that time. And then I just wanted to include 2032 and beyond because this is a big project. I want us to be very, very comprehensive in what we are talking about and thinking about. So anytime we recognize that there's important work that may not be on schedule for the next session or the next session, that we do not just drop it, that we continue the development of it. Sometimes social change takes a long time. And so the only way to make that happen is to do the work for a long time. And so we can debate all day about which things belong in which bucket, but the fact that we have all of this in our roadmap means that we will be able to include everything. And I want to talk briefly because it can be intimidating to consider a statewide ballot initiative campaign. It's a lot of signatures. There's a lot of expense involved, but I want to impress that I think it's incredibly achievable. So Whole Washington has run initiatives in the past, and we've been able to collect in excess of 100,000 signatures, which is about a quarter of what we need. You may not have heard of Progressive Victory, but they have done some very, very serious organizing for high-profile campaigns. They are a youth organization, very, very strong digital organizers. And they have a strong presence in Washington, and they are fully committed to 100,000 signatures. So just between those two organizations, we already have half of the signatures committed to that we need. The Washington Indivisible Network, I believe Whole Washington has endorsements from at least 7 Indivisible chapters in Washington state, but Indivisible has regularly been able to turn out 200,000 Washingtonians in the street for their No Kings events, and that's, again, half of the signatures we need to make the ballot. So if we are able to fully mobilize the statewide Washington Indivisible Network, they will be able to bottom line a lot of signatures. Very happy to have Katie Johnson here with us today from League of Women Voters Washington. This is another organization with strong ground game. They are a coalition partner within Healthcare as a Human Right Washington, and they have chapters all over the state. So again, if fully and properly mobilized, could collect a large number of signatures. Also shout out to Washington Community Action Network, who has a full-time phone bank and a full-time canvas. And so we partner with them in the coalition and believe that they can collect a lot of signatures as well. And then the Democratic Socialists of America have about 11 or 12 chapters in the state, most of which, and at this point I do mean a majority, have endorsed the initiative campaign. And so their estimate was if fully mobilized, they could also collect about a quarter of the signatures. And so what I'm here to say is 400,000 signatures is a lot of signatures, but if you divide that by 6, we're talking more in the 60 to 80,000 signatures per organization. And so it becomes much, much, much more achievable the more buy-in we get. And this coalition is coming together, and I do believe we will be able to make the ballot. In terms of the Get Out the Vote campaign, of course it's difficult, but I think that it's not too controversial to say that conditions to win this on the ballot are probably not going to be better than the opportunity we're going to get in 2028. It's the best opportunity I've seen in my lifetime, and we have to take advantage of those opportunities when we are given them. So that is the hopes for the initiative campaign. And for the rest of the meeting, a couple of things I want to make sure we touch on is just kind of what's going to be our meeting frequency for the rest of the year. Would monthly be too much? As we get closer to introduction, I think we may want to pick up the pace, but it doesn't necessarily have to be monthly. And then just want to maintain an open dialogue about how do we continue to engage you and your organizations. We want to show up for you. We want to make sure that we are listening to you and meeting you where you are and finding out what your best participation is. So that's more or less the content for today. I think I'm going to stop the recording now. So thank you.